cards and say, show me surprise. And I will recognize it. So that was the whole big story that you are familiar with as an anthropologist, that emotions are actually recognized all around the world. Some of these, so these are most emotions are very well anchored in all different societies. It's really not something cultural. And I did find that data shows that they are as impaired at recognizing as they are at expressing, or as impaired at expressing the emotions as they are. So the black bars are patients, and the pink ones are people who don't have the disease but are the same age, have the same cultural background, same gender, and so on. And so then we had this data that, so it seemed to make sense. Perception, action, link. People who are impaired at making the gesture also can no longer perceive the gesture. They lose it. But the question was which way this perception, action, link would go. Was it because of motor resonance, meaning, so like when you see an emotion expression, what you actually do is to do a simulation. And if it's only internal, but a motor simulation of the gesture, and because that's broken, then you can no longer understand the emotion. Or does it go the other way around? Is the visual stimulus being treated as an emotional stimulus, and they have some kind of deficit? They no longer know the meaning of, like, sadness or of surprise. They just no longer relate to the function, the meaning of this emotion.
Semantic.
It could be semantic, but semantic would yet be another thing, I think. I think a meaning of an emotion is not necessarily semantic, but maybe I'm not very proper with my own use of meaning or of semantic. But the reason I think it's two things. It's rather this kind of bodily representation of the emotion that I was thinking of. It's not the verbal understanding of sadness, but the bodily state of sadness, this kind of visceral state of sadness. I thought maybe that was lost. Could have been lost. You lack the semantic representation of sadness, so to say. So the way to answer this question was that I tested the ability to identify emotions in self and others, and so that's just questionnaire stuff. Alexithymia questionnaires test how well you relate to your bodily states. So alexithymia is some kind of subclinical syndrome, so meaning it's not something that, you don't have to go and see a doctor if you have alexithymia. Nonetheless, you have problems recognizing emotions because you don't actually know what your own arousal state means. So these are typically, and it's quite frequent, it's like 1 in 10 or something, who do have difficulty describing what they feel. They know that they're in an emotional state, but which one they are confused about. So it could have been, so one alternative hypothesis to my theory of perception action link would have been that they are impaired, that they are alexithymic, and that they don't relate to what the states mean. And it has been shown that people with alexithymia or high scores on an alexithymic questionnaire, they also have problems recognizing emotions. They have problems in recognizing emotion expressions. But because they don't really understand anymore, they don't make the link between the emotion and the arousal state. So that was not the case with our patients. If you see on the top, that the two bars are very similar. Apart from happy, and in happy it goes the wrong way around. It's the patients are more aware of their own happiness than normal people. It wasn't, in strong statistical terms, it was not. It didn't survive correction for multiple comparisons, as they say. There's some small finding there that there is a difference between control subjects and patients, but it goes the wrong way around. It's not that patients are less able to know when they're happy, they're actually more able to know when they're happy. Some kind of intuitive makes sense that if you have a severe disease, that when you're happy, you're very aware that you're happy.
I'm not sure I get it. Who are controls? Normal people?
Again, it's people who have the same age and the same cultural background, like Huntington's patients, which in my case means that they're around 50. 50-year-old people from the street or from the hospital.
HD
is Huntington's patients.
Okay, and what about alexithymia?
That's just, that's the questionnaire scores. They all did questionnaires, and then we just
that's the score. Okay.
score, to measure how well you arrive to identify and describe feelings. So
it's great to see that anger and fear is well recognized, better recognized than
normal. No, so in fact, high scores are bad. High scores mean a lot of confusion about internal body states. So that's, the mean is here and the standard error is here. So when the whiskers are very low, the two populations really overlap a lot. So in this data, overall nothing was significant. Anyways, this is the average of all of the scores. And then here, for the single emotions, it looks sometimes different, but these are very small differences. The only that was high enough to come out was this one, but because you have to statistically correct when you do loads of comparisons, you have to have a very severe level of significance, and that wouldn't be too low. It might have a little meaning. It might still have a meaning, albeit it was not statistically significant. But if it had, it went the other way around. And the second questionnaire that they did was describing feelings to other people. They were like empathy questionnaires. They ask questions about other people's. They ask you how sensitive you are towards other people's distress or pain, stuff like that. And in questionnaire, Huntington's patients are normal. There's also no difference between normals and Huntington's patients when it comes to judging somebody else's emotion when you ask it in a questionnaire situationally. So this is completely in contradiction to what they do when they have to read an emotion expression, because they don't read the emotion expression, but they say that when they are affected by somebody else's emotion when you ask them in a question. Yes, or at least they say that in a questionnaire. Yeah. That's the same questionnaire that Binja was talking about yesterday, where she tried to get at the empathy differences between So then I had the answer that it might not be that they don't understand the emotions anymore, or that they have confusions about arousal states. So maybe motor resonance. So to test that experiment that further, I used electromyography. So there you put electrodes on people's heads, on people's faces, and it's a very stylized way of recording an emotion, because you just contrast emotions like happiness and anger, and in our case we also tried disgust. So of course happiness doesn't consist only in one muscle. That's really a very big simplification of happiness. Nevertheless, when you smile, you do twitch, you do pull up these muscles. And also what's also very interesting is that when you frown, you can't smile, or when you smile, you can't frown. That's actually the best remedy to not get wrinkles at your here is to smile, because it does flatten your front. It's like anger and happy are complementary. It's either or. So this technique we use to measure different degrees of motor resonance in terms of emotion expressions. And the first task they had to do nothing, but we said it was to visual familiarization with the stimulus, not knowing that this was actually of interest to us, and we wanted to see what happens when there is no task, if there was some spontaneous mimicry of the emotion that they would see. And the second task was imitation overt. They tried to make the same face like they would see on the screen. And on the third task, it was the same experiment like they did before. They just saw the emotion word and they had to try to make the same gesture. And this was always in the same order. So really, this task would be even easier because they would have had the examples of the faces just before. There have been loads of electromyography studies on facial expressions, and they always have used joy and anger because they are complementary, and you know that anger is very here and joy is very here. And we also had it discussed because there have been a lot of discussion about disgust being impaired in Huntington's disease, but nobody really knows where disgust activates the muscles in the face. So it's not as simple. We thought it would be the nose, you wrinkle the nose, so we also put electrodes here, and we also recorded disgust. If you look at her, it makes a lot of sense. She wrinkles the nose in disgust.
Over-exaggeration, but I suppose you have to be exaggerating.
It's really, really disgusting.
It's sort of bad theatre.
Yeah. As before, we also tested recognition to see how it compared with the active tasks. And as before, we found a very strong effect that patients were much worse at recognizing emotions. And as before, we gave them the antisthenia questionnaires again, and there was no difference whatsoever between them. Now, I explained to you what you expect to see here. I have each muscle group on the top as columns. Happiness, the dramatic for the happiness, and the corrugator for the angry, and then the nose one for disgust. And on the lines you will see the actual condition, so the actual face that they should have made. So you should see electromyography activation in the diagonal and not in the other. So because if you smile at every condition, then you're not doing the task right. Like if you're always using the same muscle across the different emotions, then you're not doing the task right. It should only be in the diagonal and not be in all the other squares. And so the first task is the expression from words. And you see that it works. So what you see, what's nice is that in the non-conditions, for the happiness, neither in the angry nor in the disgusted conditions, there would be activations of this muscle, in neither the patients nor the controls. So there is emotional specificity in the activation, and we find it for both patients and controls. So the controls are on the higher one and the patients are on the lower one. This shows, on the one hand, that the patients that they're both doing something in the right direction. So the patients are not just doing nothing, but also it shows that they are impaired compared to control. So they are significantly lower in their specific activation of the right muscle for the right emotion. And the same thing is true for angry disgust. So our interpretation of these two is that this diagonal does not like say for disgust, the nose is not the strongest activation. It's actually, the nose is more activated when people are making an angry face. And the disgust also makes you wrinkle. So then we have a problem with specificity here between anger and disgust. Yeah. That was our risk, because Sorry?
Because it's taller, it means there are many different behaviors.
Yeah, when the whiskers are really big, that means different people don't do the same thing.
Yeah.
So some people use a lot of nose when they are angry, and others don't, and the other way around. And this was the most crucial condition. It was the imitation, because imitation doesn't require you to understand what emotion it is. It's really only motor reproduction, if you want. You just have to do the same thing as you see. It's actually an action. Okay, so it is an emotion. You don't have to do any emotional treatment. You can just do what the photograph in front of you does. And if that is impaired, this is support for the resonance theory that we have. And we actually find that this is true. What's interesting is that it's true. So the difference between the patients and the control subjects is especially big for the negative emotions. And you can see that the controls are also lifting up a little bit higher compared to the patients, but it's not statistically significant. It means that the patients are not that bad at imitating a smile on command. It seems like the smile is not the same than the negative emotions.
So this invalidates your hypothesis?
It's partial. It says, like, globally, we see that they are impaired. They're impaired more.
But isn't it, and I might be wrong on this, but I read that it's easier to smile than to...
The smiling it's a special case, if you want, because it's not only about negative emotion or positive emotion, it's also some sort of social gesture, politeness gesture. We're over-learning also to smile in reaction to a smile. It is really some kind of conditioned thing. And it seems that it's so well learned that it's holding longer. It's still there, even though they have difficulty. In most emotion recognition experiments, Huntington's patients are not significantly impaired with smiling. Just in this very replication, at the same time we did the EMG study, we did find a difference in happiness, but that was because none of the subjects made any mistake. So then they were at ceiling, and any little mistake from a patient would just already bias the difference to be significant. And so,
but that's not what I meant. Again, I might not be remembering it right, but I'm not sure what it is. Is it true that there are more muscles that are used to smile?
Oh yes.
But it's the action is not rhetorically, kinesthetically easier than frowning, which uses fewer muscles.
I don't know. I don't know that physiological background of the smiling. At any rate, so just sticking 2 electrodes here and 2 electrodes here and saying we are measuring smiling and we are measuring anger is very simplified. So for a proper smile, you need more than just a little twitch on your cheek, and for a proper anger, you need more than a little twitch between your eyebrows. So in a way, it is a more objective measure than to just look at somebody and say, is he angry or not? But this is some kind of a typical, I think, way of a scientist to react. So we're using electrodes, so it's objective. And then the stimulus is so poor that really the interesting thing we're losing. So it would have been easier, I think it would be more valid to have done what we did before with the videos, to film people and have the videos rate, and have people rate the videos and see if that is still a smile, if that is still, if you would still qualify.
What I meant was that if it's easier to do, then it would be easier for someone who has some kind of motor.
And I think it's easier. I'm not sure that I know that physiologically it's easier.
Overlearned.
Yeah, that's another. So one reason it might be that physiologically it is easier. I didn't know that. I might be able to check, and I think it would be a nice thing to add. And the other thing is that it is easier in terms of its social function and being overlearned and overtrained. And since you are 3 months old, you know, it's part of your gesture of your social
At
life.
the same time, both emotions appear very early in ontogenesis, like very baby of 3 days. They express both of them.
And you get, the babies get a lot of reinforcement for smiling.
Yes, enormous.
Yeah.
So this is the last condition that was, it was actually the first in experiment when they were just told to look at the faces, not do anything. And what you want to see is an interaction, a different difference between happy and angry in the two muscles. So the signal gets much slower than the one you saw before. So this is now no longer across the whole development, it's just binned some average score across the whole duration of that they saw the face. And you see first in the control subjects, which are in white, that they do show more activation for happy compared to angry when they see a happy face, and that they see more angry than happy when they see an angry face. And what's less easy to get your head around is that here is only a difference that's significant. Both activations are actually lower than the baseline, which means that when you look at faces, you seem to frown a little bit because you're paying attention. So again, we have other things that we're measuring with the EMG than the actual thing we want to measure, so like concentration is also when you're frowning. And so what then happens in normal subjects is that this just goes away. That's what I said before. So this frowning, that's task related because you're staring at a screen, goes away a little bit more when you see a happy face. So it really seems that the two expressions are complementary. When you smile, it eases your frowning. And this effect goes away in Huntington's patients. You can see that here. And it does also go away in the happy, so they do no longer resonate with the stimulus in the screen. And then this is brain. So then we try to correlate those scores we got, the imitation score, and the recognition score, and the expression score, with changes in gray matter density of the patient's brains. So these are only the patients at that stage of the analysis. I only had patients' brains, so I don't know anything about the normal brains. Because it's a hospital and we can only have patients putting in the scanner on normal people. And then you can do a correlational analysis of looking at differences in density of brain matter, gray matter in the brain. So there's inter-individual differences.
Density of gray matter.
Yeah.
So it's there, or it changes.
So between subjects, well, we have very different brains, but you do in analysis, you normalize the space and you kind of roughly overlap all those, so then you can compare and look at. But like once you have done some kind of averaging across the brains, you can still look at what's still different between your brain and your brain and my brain. In terms of gray matter, yeah, in structure. And you can look at what's the difference between all these brains, correlating with the scores. So, because you have a score of 7 and she has a score of 8 and I have a score of 6 in this imitation, like the amount of activation I show gives me the score, and then I correlate the score with changes in the brain. Meaning that these changes, these differences in our brain correlate with the differences in our behavior, suggesting that this behavior is treated in this area of the brain. Do you find it easy enough to make that link? So now, what's interesting is so where in the brain is that? And the first column, the caudate body, is not, maybe it's not that interesting in that it's a major area that patients have atrophy in. So of course we would expect this to be implicated in the task because they are, it's the very first thing that you would look for because we know already that they have really strong changes in that part of the brain due to the disease. And what was more interesting is the second column, inferior frontal gyrus. It's where the neurons and it makes sense to suspect that changes in density which might relate to atrophy, might relate to just around this where the brain works. These changes are differences in how well they what's interesting is that we have inferior frontal gyrus throughout the three conditions. So it's for recognition as well as imitation, as well as expression of the emotional expression. This really supports most perception action link. It's just less well thought of in the emotional context. In action, but its role of emotion is just less talked about. This is now the action part of emotion. And that would be my point. That consequences have a problem with recognition because the action part of the emotion. And the third column, there's two different findings. So recognition, we also found a relationship to insula. Insula is part of is secondary somatic representation of the body. So the first would be somatosensory cortex, and that's actually what we do. That is primary input of skin proprioception. The S1 block of the brain represents where the body as a surface is represented. And the insula receives projections from the somatosensory cortex, but also from the gut. The insula is finally the gut's representational structure, and it is it is the one where the opinion people have differential activity. Ones who have problems that they can find and this one we only find in recognition as substance expression and imitation. Yeah. And the superior temporal it's funny. The third column really is the difference between the me and you representation of emotions, whereas the other ones are the common space. Is where we have a co-representation of me and you. And what I described to the superior temporal surface is this kind of relay function where you switch views between my and you. And those plays well in understanding you because they rematch. Yeah, that's one thing. That's one thing that I like in the discussion. So what this means for you now. We have parents that we have problems with the gesture. But at the same time, they don't have problems with identifying situational emotions. And another paper, another group, they did experiment they showed the gesture, semantic gesture. That would be what I would call semantic gesture. You don't see the face, but you just can you make the face So, interestingly, patients are not impaired and telling that this is discussed. So you have something that you can still use to communicate emotions towards your patient who will no longer be so easily reading your body. It becomes kind of blind with respect to action. You can use emotions to communicate. And I think this is an important thing to say to people. Look, it doesn't help if you frown at them. They're confused about what that means in terms of body, in terms of action. Choose your words, which is not very easy. Because that's how you notice that the emotion is very immediate. If you have to say, it's so much more, you're looking for words, and you are in the state that it all comes through your body, but the other person can no longer.
What they said in the questionnaire is reliable.
Seems to be reliable, seems to stay well with the I did apply, but there was one application I nobody was very much interested. But one thing that I will do is to move that their access to the body. And I think, so this one also, somatosensory cortex also means body representation. So your body representation is obviously implicated in action. Even emotional action, but it's not immediately affected in Huntington's disease. The neurons don't die there as much as they die in the caudate body. So maybe if I'm hoping to show that with dance practice, you can actually support by structures you do not degenerate. You can support the others, so you can just stay better at reading actions, your own and other people's actions. Yeah, so that's what I will do. I will see what the training actually changes, hopefully positively in the brain. Yes.
Enriching medium or English. Maybe
enriching
but another way, like from practice, you should, in practice you will emphasize imagination, what's happening inside, and imagination might be, might help in feeling things, maybe if they are more.
I don't have problems with the feeling, and I think what's most important is that we train the caregivers in their expression, because they don't have a problem with expression, but they have a problem by being no longer understood in their immediate expression, so they have to kind of go on a detour if they want to be understood. It's like the other person has become blind to their immersion expressions, and now they have to come up with a sign language for immersion expressions, and then they have to use symbols, and they have to be trained. They have to be given tools to communicate emotion expressions in a more indirect way than what we normally
And doing
immediately do without even thinking about it, just communicate through our bodies what we feel for each other. It is, I think, the question of the caregiver is really very badly neglected. Like since we have this perception-action link, since we represent the other person's emotion and action with our own system of emotion and action, the caregiver is immediately affected by the illness of somebody.
What's the meaning of
Caregiver, the person, yeah, like it could be the partner, but it could be a sister, or it could be a friend, it could be somebody helping the patient. And I just see how if a person has motor disease and moves all the time, because of this motor resonance that we have in normal people, the illness is getting into your brain through this action, resonance, and all that goes with it. So the person can no longer express properly. So you don't understand what they express, but they also no longer understand what you express, and this whole communication just breaks down. But you don't have a disease, only your partner has it. But you are still impaired, and maybe as much as the other person. But you're not being looked after by any doctor because your partner is sick.